that refer to any adjacent fractures that occurred. So I agree that there's not enough research. If there's a return of pain, there needs to be other studies performed and not just call it a failure of the vertebroplasty. And my own father suffered severely, could not move, had vertebroplasty by an interventional radiologist, because I don't do them, and he was fine within hours of having the procedure. So you cannot deny this to patients who need it. We cannot deny it just because there is not enough literature. So that's all I need to say. Thank you.
Thank you. Operator, the next commenter, please.
And your next question line of Dr. Patricia Byers.
Oh, hi. I'm a CAC member. I'm a general surgeon representing the Florida chapter. I don't have any conflict of interest. I'm just curious about the studies that show no improvement of pain. If those studies were done after the patient was on opioids for a period of time, would not that interfere with the patient's improvement? Because if you're on opioids for any more than a week or so, now that we know about the opioid epidemic, someone would continue to think they have pain because of their opioid addiction, no? So I was wondering if there was any studies that tease that part out of it.
We could open that to subject matter experts, but I can probably help with this, Dr. Haug. So I just want to clarify first, the studies versus the basis of the challenge to vertebral augmentation in the Cochrane review and or the recently published paper in JVMR is not that vertebroplasty didn't work. Vertebroplasty has historically worked in all of these trials. It's the performance of the sham arm. And I think that's just an important distinction that was made by one of the other subject matter experts earlier. And the subject of opioids is extremely important, and clearly many of these patients are on opioids. And in fact, in a different era, many of us thought they really should be on opioids before we would go ahead and offer augmentation, meaning that was considered an active part of conservative therapy. Thankfully, after years of thinking that and a lot of, I think, challenges to not thinking that way, I think there's been an evolution in thought about what conservative therapy should look like. But I would say, in answer to your question, clearly a large percentage of patients in the trials are on opioids, and one of the benchmarks that the trials use is how well people do coming off opioids once they've been treated. And I would say that across the plurality of real-world comparator studies, vertebral augmentation offers a significant advantage in that case. I would open the comments up open to other subject matter experts.
Operator, if we can go to the next commenter.
Your next question line of Dr. Melissa Chambers.
Hello, this is Renee.
Yes, we can hear you.
I'm a neurosurgeon at UAB. I'm representing the American Association of Neurologic Surgeons, and I have no conflict of interest. I would like to only reiterate the comments of both Nelson and Josh when they made what I think is one of the most important findings to date. That is, there are many unique combinations of clinical and imaging factors that might affect not only accurate diagnosis but also treatment choices. So I think this particular issue, we've sort of skirted around it because as Dr. Hirsch pointed out, we have so many randomized controlled trials, we have so many studies, we have prospective and retrospective patient experience reviews. I think probably this has been addressed thoroughly by both the European and the American clinical care pathways that were developed by the multi-specialty panel with the RAND, UCLA, appropriateness method, Dr. Hirsch mentioned he was part of that. I was as well in the American pathway. My point is there are so many different factors involved here. Presently we're talking about non-surgical management interval of time. And then as we go to question 12, we'll be looking at pain and its progression, loss of vertebral body height and its progression, progression of symptoms in general, impact on daily activities, advanced imaging findings, and so on. I think timing is just one factor among all of these. In my opinion and my experience, we published in 2015 an article that's not on the list, just the patient experience following over 200 patients. And I think the patient experience is significant, rapid, sustained reduction of pain, improved quality of life, reduced disability, and a low complication rate. I think we've all agreed those are relatively common findings, agreed upon findings. I think that timely repair of the fracture is indicated not only to prevent complications that Dr. Tracy pointed out associated with prolonged inactivity, but also just for humane and effective treatment of severe pain in the acute setting. But if we go to the literature, I think the clinical care pathways are the closest we can come to addressing each of these factors in their unique combinations to say, yes, literature does provide reliable, valid information to use for treatment choices. That's all I had.
Dr. Chambers, and you're familiar with Virtus 4, right?
I am.
So in that case, the sham, similar to the New England Journal studies, was in itself a form of treatment. Would you agree with that?
Now, remind me, I say I'm familiar with it. Is this the bupivacaine?
Yeah, and periosteal injection of bupivacaine.
Yes. I think that is an active sham.
Okay. And they didn't find a statistical difference. I guess you could argue if you increase the numbers enough that maybe even a small difference would be statistically significant. Do you think that that itself, that injection, periosteal injection, should be part of the treatment algorithm?
Part of the treatment of fractures?
Yeah. I mean, it was an active treatment, and its results were equivalent, arguably, to the vertebroplasty. So, should that be tried alternatively to vertebroplasty, or at least be part of?
Go ahead. I'm sorry.
No, you go ahead.
Well, I think those are two different treatments for two different problems. I think what happens is the injection introduces yet one more confounding variable into these trials. Where is the bupivacaine going? Are you simply infusing anesthetic subperiosteally, or are you providing a medial branch block? Are you injecting the facet joint pain? Are you injecting into the musculoskeletal tissue and relieving myofascial pain? I think these are two separate issues. I don't think that you want to compare vertebroplasty to this injection. I think, as I was stating about the unique combinations of pre-treatment findings, I think you have to do your very best to make an appropriate diagnosis and decide what you're treating. I don't think you just need to, like the label trial, just take bupivacaine and inject it to then say, well, this was not the result of relief in the INVEST trial. I think these are just two completely different things. I think you'll muddy the water if you try to create a trial comparing sort of a random subperiosteal injection to a procedure specifically to stop the fracture pain.
Well, I mean,
does that make sense? I think they're.
Yeah, no, but I would push back a little in that, the authors of Virtus